everyone. Throughout the semester, our team reviewed the literature to understand the effects of intermittent fasting on obesity and obesity-associated metabolic imbalances to better understand if this could be used as a solo or supplemental treatment for obesity and obesity-related metabolic imbalances. So in this presentation, we will discuss our findings and our translational research plan of action. When developing a project for implementation, all stakeholders should be considered for various parts of the process to ensure successful implementation and evaluation. The team our group developed consists of 2 to 3 lead clinicians in a primary care clinic, IT department staff, nursing, and patients diagnosed with diabetes. Obesity affects 1 in 4 Montanans and around 1 in 3 adults nationally, and the accompanying metabolic imbalances often lead to complications such as insulin resistance, high blood pressure, hyperlipidemia, and even death. Despite treatment efforts, the obesity epidemic continues to grow. The failure of conventional calorie-restricted diets necessitates a review of the current research of treatments for obesity, as well as an assessment of the feasibility of incorporating new evidence into practice. The traditional method of eat less, move more has not curbed the obesity epidemic and sets the obese patient up for continued weight gain as the hormonal drivers of obesity supersede the best efforts over time. Because of the largely ineffective current practices, finding alternative or supplemental treatment options for treating obesity is essential. Intermittent fasting, defined as an eating pattern that cycles between periods of fasting and periods of eating, is demonstrating promising data on its benefits for obesity and obesity-associated metabolic imbalances. Intermittent fasting is actually just an umbrella term for various methods of eating schedules that alternate between fasting and eating. Many of these methods exist, and some of these include 24-hour fasting once or twice a week, alternate day fasting, intermittent calorie restriction, and time-restricted feeding. The most common method we found after conducting our literature search was the time-restricted feeding. A recent review by the New England Journal of Medicine describes the health benefits of intermittent fasting on health, aging, and disease due to mechanisms of metabolic switching and cellular stress resistance. In a review of the literature, intermittent fasting was compared to calorie restriction in both weight loss and metabolic measures. A lack of consistency between methods of intermittent fasting, as well as studies in uncontrolled environments, make analysis difficult. A small but well-controlled crossover study by Sutton and colleagues did find benefits of early time-restricted feeding on cardiometabolic health and concluded the clinically significant improvements in health were independent from weight loss. A 50-week randomized controlled trial by Schreubel and colleagues reviewed intermittent calorie restriction versus continuous calorie restriction and found that intermittent calorie restriction is equivalent to, but not superior to, continuous calorie restriction on body weight and metabolic indicators. A systematic review and meta-analysis by Cho and colleagues found intermittent fasting improves glucose metabolism through lipolysis by confirming the difference in body mass index, homeostatic model assessment of insulin resistance, leptin levels, and adiponectin concentrations among the participants. The overall number of participants included in the analysis was small, however, and the methods of intermittent fasting were not well defined, which makes interpretation of the results difficult.
Thank you, Melissa. Our group had 3 aims for this translational research project. We wanted a better understanding of intermittent fasting's effect on body mass index reduction in those diagnosed as obese. Additionally, we wanted to understand how and if intermittent fasting improves the metabolic imbalances that accompany obesity. And finally, we wanted to determine if intermittent fasting was equivalent or superior to the traditional regimen of calorie reduction, to see if this was an alternative treatment option for those who had failed calorie restriction diets in the past. The RE-AIM framework has an emphasis on health promotion as well as addressing an intervention at the individual level, which is why we chose this framework for our project. There are 5 steps in the RE-AIM model. The first is reaching the target population. Our population focus is patients with body mass indexes of 30 or higher who are interested in weight loss and correcting metabolic imbalances. Next, we are looking at the effectiveness of the intervention, an evaluation of pre and post outcome measures such as body mass index, blood pressure, inflammatory markers, cholesterol and glucose levels, as well as quality of life measures will help us determine the intervention success. To develop the organizational support needed to deliver an intervention, we need an adoption by the target setting or institutions. Outside of the primary care clinic, we can utilize the Public Health Administration to help communicate and deliver information on intermittent fasting as an option for obesity treatment. Implementation consistency of the delivery of intervention is important to ensure congruity. Education modules and seminars with clear guidelines for prescribing and monitoring intermittent fasting can be used. And finally, maintenance of intervention effects in individuals and settings over time ensures long-term success. Continuing education opportunities and public health campaigns are 2 ways in which we can do this. Additionally, communication with medical and nursing schools to encourage incorporation of more nutritional education into curriculums is another means to ensure intervention adaptation in the long term. Understanding attitudes towards behavioral change is imperative to an intervention's success. Because of this, our group believes the theory of reasoned action is an appropriate change theory in our project on intermittent fasting. The theory has been used to describe an individual's intention to change behavior. Providers need to address their personal biases and resistance to change, and even more importantly, we need the patient's buy-in for change to occur. 3 areas for the provider to address with the patient include: does the patient perceive the change is important? Does the patient feel confident in his or her ability to make the change? And does the patient place priority on the change with the time being right? I now turn the presentation over to Shannon.
Hi, thank you, Hillary. Now we are talking about the academic detailing piece. As with RE-AIM and the theory of reasoned action, academic detailing addresses change on an individual level and focuses on the needs of the population and the provider by tailoring to the needs of both. Our team used educational research visits for the primary care team performed by a trained consultant, presentation of evidence, practice guidelines, and outcome measures. We will use auditing and tracking tools, educational material, and available resources. For our evaluation step, we chose the pre-post measurement. The pre-post measurement in 1 cohort method. This will assist our group in evaluating the success of intermittent fasting and the implementation by evaluating outcomes. We're going to be measuring pre and post body mass index, blood pressure, cholesterol levels, glucose level, markers of inflammation, and quality of life measures. The potential impact of intermittent fasting. We think as our team has gone through this process that offering an alternative therapy option for the appropriately screened obese patient could be beneficial. We think that the improvement of metabolic indicators and quality of life are important pieces to consider. Improvement in long-term adherence to an eating style would make us think that this process and project are successful. Reduction of stigma and talking about obesity, and reduction of stigma from people who live with obesity, increasing understanding of obesity and the hormonal drivers that curtail weight loss efforts will be our impact. For the dissemination of our project, we would do a compilation of an exhaustive literature review listing the strongest evidence first. We would compile an executive summary using bullet point format for ease of reading, with links to our data, literature review, online forums, and listservs for more information. We could submit our project for publication to a mainstream journal, like ANA's American Nurse. We could use the data from our already functioning audit system to collect our indicators such as BMI for the patients using intermittent fasting. We could share that information with our greater committees, who then also share that information with executive committees, including large hospital board systems. And then we could submit our project for poster presentations at conferences and share our information with our colleagues. Thank you very much. This is, again, Shannon and Hillary and Melissa. Thank you and have a good day. If you have any questions, let us know.